All right, we'll get going here. Well, I am super excited to welcome. I'm going to call her Professor Elizabeth Woodcock. Because she has been a guiding light for us here at Luma for well over a decade. We're really excited to have Professor Woodcock here. She is the founder and executive director of the Patient Access Collaborative. In our opinion, one of the leading thinkers and really community builders for academic medical centers, but really for the patient access community writ large. So super excited to hang with her here today. I was sharing this with her backstage, but when we launched Luma a little over 10 years ago, Elizabeth is the OG of all OGs. And so she was really the only thought leader writing about the importance of patient access, equitable access, how important it is to drive no-show rates down, the concept of a wait list to get people in sooner. And when Luma launched nearly 10 years ago was with a smart waitlist product as our very first entry point to help clinics find people who are waiting for care, find availability in the clinic schedule, and make sure that match happens to get people in sooner and people who are waiting weeks to months out to get them in and just make that magic happen. So we're coming full circle here, and now we get to hang. I'm actually, this is not my normal background for those of you who join our ongoing digital health on air series, but I'm only stone throw away from your alma mater, Professor Woodcock. We're over in Greensboro, North Carolina today, so about an hour, 25 minutes from Duke. But we have the Luma squad here today, spending time together. So thank you for joining us. I really want to turn it over to you, and we'll kick off. We'll hand it off to you to share more about what you're focusing on today at the Patient Access Collaborative. I know last week was your annual Patient Access Collaborative Symposium. Like, what are some of the things that are top of mind for you, for health system leaders who are part of the Patient Access Collaborative?
Yeah, I really appreciate the shout out, and I'd like to make that mutual. I'm so impressed with Luma's vision related to equity. You're one of the very few suppliers that really has that at the heart of its mission. And so you mentioned this term community. Really, the Patient Access Collaborative is a learning community. We have access leaders, almost 4,000 from academic health systems. And a lot of folks ask me, like, why academic health systems? Well, I think really what we're focused on is the very large, complex issue with the layer of training and research on top of that, and still trying to deliver the best care in the most equitable manner. So we put together this community of leaders, and we're really thrilled to say that 1 out of every 4 ambulatory visits in the U.S. comes through one of our members' doors, and our focus is really on that knowledge share.
Well, that is real impact at scale. Like a quarter of Americans are coming through members of the Patient Access Collaborative's doors. We patient access, digital front door, health equity are often used as clickbait for folks in all the different journals and magazines out there. But you've really been at the forefront of this for well over a decade. As you think about the health system leaders, the learning community that you referenced, like, what are the real specific barriers or challenges that you see to patient access to make sure people get to the care that they're looking to get to?
Yeah, it sounds so simple too, because barriers, I mean, we all experience them as patients. However, I think in healthcare, we have kind of a black market. Like, we know who to call, the right phone numbers. We've got the backdoor channels. So one of the things that we kind of have to rise above is, to really understand what these barriers are. And honestly, many of them are ones that I would argue we've created. A good one, as just as an example, is requiring a medical records review. This is, I would say, not just common, it's almost ubiquitous in an academic medical center. We've become more subspecialized. And so, we need to vet, we need to make sure right provider, right patient. Like, I get the genesis of this issue, but it has really become a barrier. And that's an internal one. And of course, then we're also contending with external barriers. For example, we've got prior authorizations up the wazoo for ambulatory clinic visits. Now, that really hits us in certain markets, like very managed markets like Chicagoland market, as we move out west to California. But what's interesting is we've got both internal barriers that we're addressing and external barriers as well. And then, if I may mention, I think the real powerful ones are the hidden barriers. For example, the fact that we don't even think about, when we remind patients about their appointments, super simple process, super simple workflow, it's all in English. Despite the fact that our patients do not all speak English as their primary language. And most importantly, we've actually confirmed that they don't. So we go through this whole process related to registration, and then we're like, oh, did we ask you that? Oh, sorry. We've completely ignored that fact in all of our workflow. So I think of that as really super difficult for time-starved families, for time-starved patients. We've added this extra layer of complexity that's really unnecessary. So that's what we're doing in this community, is identifying, analyzing, and working collectively to locate solutions.
Awesome. That's super helpful. I love the framing around internal barriers, external barriers, and then of course the hidden or unseen barriers. As a community was together last week, look, there's been a proliferation of digital tools, all sorts of technology, be it portals, be it messaging, be it the digital front door word gets thrown around pretty loosey-goosey. Like, what are the real solutions that your members have implemented or are looking to implement, especially as you think of a patient as a consumer and someone who has so much more choice?
Well, I mentioned language. That's one of the areas that we're really focused on. Written communication is a big area. Those appointment reminders, how we message in patient portals. We're also looking at oral communication. So it's interesting. We have several presentations about Spanish language call centers. So this is actually had some really interesting hidden opportunities. And that not only is this awesome for our patients, but we've realized this is a big employee retention opportunity, because as we are frustrated or see our patients frustrated with us, we actually have failed to recognize that we have a lot of team members, a lot of associates who are desperately trying to help their own communities and unable to do so given those hidden barriers. So I think really kind of focusing on patient choice and how we deliver communications both orally and in writing. We're also taking a look at geography. It's really interesting because we think about, especially an academic medical center, right? You got to go to the city, you got to get into these massive buildings. They're all called crazy names, and they're, clinic A, B, and C, hello. And then many of our academic health systems have expensive parking rates. I mean, it is, when you really step back and think of it, it is barrier, 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 like that has just built up over the last, 20 to 50 years type thing. So we're starting to look at, okay, how do we think about virtual care? We went through COVID, telemedicine, but it's like next level. How do we be intentional about it? How do we work with our community resources instead of just stand up there and say, kind of ivory tower situation? But honestly, I think what we've realized, and this is being very transparent, is all of that sounds awesome. There's some real foundational work we have to do. We went with electronic health record systems 5, 10, 15, 20 years ago. We asked all of our patients, including me and you, what's your address? What, is your language, preferred language? But we left out a lot of questions about gender identity, for example. How are we even managing houseless persons? Who knows? Right. We all require addresses. What if you don't have an address? So I think this foundational work is really critical. And I think it reflects that hidden barrier, but it's really important.
Okay, super helpful. I think this is fantastic in terms of one, you've outlined very clearly that there are patient access challenges and health equity challenges across health systems, and especially the very large academic medical centers that you partner with and the community that you have. I love the focus on very practical, tactical kind of starter tips for health system access leaders in thinking of, hey, what are areas that we can move the needle on and move the needle on, probably with lower lift, be it language, workflow automation. I think the key there being it's not just workflow automation for patients, but also staff and providers. You have to think of all the stakeholders, and then of course using technology in the right way, be it telehealth, virtual care, etc. I think we hear pretty consistently from folks that the intention is like we want to be able to deliver a stellar healthcare consumer experience. We want to be able to deliver excellent access. But in your example, for the organizations that have really done it well, what's allowing them to do it really well versus those that who may still be struggling with it?
I know this is a very simple answer, but I would say listen. Like really, really listen. And this is more difficult than it seems because historically, as health systems and providers, small practices, we've used our patient satisfaction surveys to be the voice of our customer. And what's happened in patient access is we've realized, those are only the patients who've actually made it through all of these barriers, can read in English, fill out a form, and then get it back to us. So, like, this is such a biased sample. Any expert surveyor would say, like, okay, guys, like, really, this is an opportunity for improvement. And that's why listening is really, really important. And we are hearing ourselves say, for example, appointment no-shows. Think about what that means to a family who can't make it, doesn't have the transportation to get their child into that, 2 hour away parking deck, doesn't have the money to pay for that parking deck. And you say, oh, you no-showed, and then we say, oh, well, here's $25 you have to pay us. Like, really? So we're turning that around and we're saying, okay, let's figure out how we identify our high-risk patients. Let's go ahead and place outbound calls or outbound text communications in the patient or family's preferred language. And let's ask, how can we accommodate you or how can we accommodate your child? Right? Mind blown. Such a simple, effective way of like turning it around and realizing we've got to do better for our patients. So I'm going to go back to listening.
No, I love that. I think we always say keep it simple, silly, but this makes perfect sense. Starting with listening and then really turning that into impactful tactics and results and people process knowledge improvements, like you articulated. I think we often have heard, well, I shouldn't say often, we've seen an evolution of primary care, 1.0, 2.0, 3.0. There's, of course, the Walmarts of the world have stepped out of the game. The Amazons of the world are like shrinking their footprint. Same thing with the Walgreens and CVS's. I know primary care is a big topic of discussion at academic medical centers, where it's like, how do we balance primary care versus specialty footprint? And ultimately, if you can't get access right for primary care, like, will you be able to ensure access for follow-on care? Like, how are some of your member systems really thinking through the reality of primary care today and ensuring that there is real equitable access for all the people in their community?
This is a really, really big issue. And I think I'm going to argue is greater than us in that supply and demand are fundamentally out of balance in the US. That is, we have too many patients for our providers today. And unlike, you referenced Walmart, who, if there's not milk on the shelves today, can likely get it in the next hour, if not the next day, or like you go milk a cow and you've got it the next week. We can't get a neurologist for 11 years. Like, there's such a big, supply chain issue that's really, really fundamental. And so transparently, we're struggling with that. We're trying to figure out how to really take down these barriers as a way to open up access, and really realizing that we have to work on not only the demand side, getting the patient to the appointment, but also we look at the supply side. So we have a huge body of work related to capacity management with the intention that we need to build the scaffolding for our communities to have the optimal use of our providers' time, right? If we can't get another, neurologist for 11 years, then we got to make sure that we do the very best we can with that precious asset we have today. So I don't have an answer for that question about primary care, specialty care, but I will be a voice of it is a problem. And we're really trying to address those barriers in addition to thinking about how we make better use of our precious asset, our provider's time.
Absolutely. I think just to go a little deeper on the supply and demand topic, you've often written in when I've heard you in the past talked about the airplane analogy in terms of booking in advance and just how things have worked out in that industry and what we can learn there. I think things you want. I think there's some relevance here to what we just talked about. Things you want to share with that analogy and how we apply it to the supply and demand issue.
Yeah, the airline analogy, I think, is a great one. And to layer on top of the issue of the airline analogy is not only do we only have X amount of seats to sell, but we have two really big issues that, we contend with that Delta and United Airlines don't. Number one is we can't sell first class seats. So Delta can make
Hmm.
some yield management decisions by saying, okay, well, I may have too much demand, so I can raise my prices and I can, get more money for this, get more money. We can't do that. Our hands are held. Of course, this goes deep into kind of reimbursement in the US healthcare system. We are held to an allowable. We can't really use price as our deciding factor. And then, of course, we have the other issue, which is if we oversell, right? Delta has a plane in the next hour, the next day to get you to Cleveland, Ohio. Our time is gone, right? We don't have our provider's time. It cannot be inventoried. So we don't have that second seat or that other plane we can put on the runway to sell. So yield management, I think that's why we use the term capacity management. I think it's a little bit different in the healthcare space and more difficult, I would argue, to manage. But it shouldn't be that we give up. And that's what we've done historically. We've just thrown our hands up and like, well, there's too many people, so let's make sure they fax us their medical records. What the heck? I mean, who's going to be there to fix these fax machines in 5 and 10 years when nobody even produces fax machines? And here we are in healthcare. We just use faxes everywhere. So we've really got to start deconstructing those barriers and not just give up and realize, oh, it's too complex. We can't do it. We've got this. It just has to be a little bit more intentional than we have in the past.
Well, I know we're coming up on our time here. I'm always smarter every time I listen to you. So thank you for sharing your time with us. I'm going to come back to what you shared with all the different health system leaders who are tuning in. Start with listening, right? Like keep it simple. Start with listening. And digital transformation is a big word. It's a mouthful. It can feel hairy and scary. But if we listen, turn it into practical things to really implement and change for patients, staff, and the providers, that's the start of transformation. So thank you. Since I love hearing from you, like any final takeaways that you want to leave us with?
Well, I just want to kind of go back to that opportunity of listening and really to understand that if we don't, the price that I talked about, which is, kind of we think about it in reimbursement and what insurers pay and patients pay. But honestly, the price that is being paid is by our most vulnerable patients. I say that because their voices are not being heard. And because of that, they're fighting to get in our system. They're getting sicker. They're coming into our EDs. And so if we can take the time to listen, we will find that that transfer of price, which is the desperation, the phone calls, the trying to find somebody to help, that's the price that our most vulnerable patients are paying. And we've got to stop that. We've got to stop that. And we've got to use, companies like y'all's to really be able to be great partners to solve some of these problems. Instead of giving up, there are solutions. We just need to be more intentional about it.
Awesome. Well, sage words as always. Thank you for your leadership, for bringing the community together and delivering impact in so many ways. So thank you, Professor Woodcock.
Thank you.